I want to welcome everyone to today's hearing. Before we begin, I would like to ask unanimous consent for our colleagues, Representative Cathy McMorris Rodgers from Washington and Representative Mark Takano from California, to join us on the dais this morning and participate in the hearing. Should they both be able to attend, I know that Ms. McMorris Rodgers is probably finishing up a meeting, and I'm guessing Mr. Takano is too. So without objection, so ordered. Approximately 40,000 providers are privileged to deliver care at VA's 170 medical centers for the roughly 9 million veterans who receive medical care through the VA. Ensuring that these clinicians deliver safe, quality care is a vital piece of fulfilling VA's mission to provide our nation's veterans with the services they've earned. That same mission obligates VA to hold providers who deliver substandard care accountable. An important part of ensuring that accountability is the accurate and timely documentation of problems and communications with outside entities such as the National Practitioner Data Bank and state licensing boards. Refusing or failing to adhere to reporting requirements puts not just veterans, but all patients across the country at risk of receiving substandard health care. Today's hearing will explore how VA fulfills its obligation to hold privileged providers accountable by communicating with these entities and ensuring the timeliness and accuracy of such communications. This week, the Government Accountability Office released a report requested by this subcommittee that explores tremendous deficiencies across VHA in this particular area. The report found that among the sample sites, VA officials at the local, regional, and national level consistently failed to ensure that the facilities were adhering to reporting standards and requirements. This resulted in repeated failures to appropriately report incompetent providers, who in turn were free to continue giving care within VA or out in the community. The burden of ensuring that these providers deliver safe, quality care to veterans naturally rests with the medical centers administrators, who are responsible for overseeing the delivery of health care services. However, GAO found that the sampled facilities frequently fail to maintain and provide sufficient documentation when reviewing or reporting providers. Moreover, some reviews and reports were initiated months or even years after problems were identified. Even worse, GAO found that facilities failed to report offending providers to the National Practitioner Data Bank and appropriate state licensing boards in almost all reviewed cases, leaving these providers free to continue practicing unchecked, sometimes in another VA or in the local community. These findings show a disappointing lack of commitment to the veterans receiving care from the agency and facilities charged with their well-being. Further, GAO found that VISNs and VHA have failed to provide the oversight needed to ensure that VA medical centers are addressing these issues and reporting providers when appropriate. While it makes sense that medical center officials are directly responsible for the integrity of the providers they employ, the VISNs and VHA should and do have an obligation to exercise strong oversight over these competency and privileging processes. Unfortunately, GAO found that VISNs failed to audit facilities' provider reviews and did not consistently utilize the standardized tool designed for these oversight activities. Having any underperforming provider continue to deliver care to within the VA and to veterans is not only troubling, it's absolutely unsatisfactory. However, according to GAO, VA failures in reporting quality concerns allows subpar providers to not only continue administrating care, but also to continue to be eligible for bonuses related to personal performance. Unfortunately, this news is not new to the VA. A 2013 GAO report highlighted that VHA lacks information about how performance pay decisions were made and whether these decisions actually reflect providers' performance. Clearly, VHA's oversight efforts continue to fall short. That these issues have persisted unaddressed for 4 years after being identified by an outside entity indicates a worrying lack of urgency on VA's part. I look forward to discussing potential solutions to these persistent problems with today's witnesses. With that, I now yield to Ranking Member Custer for her opening remarks.
Thank you, Mr. Chairman, and thank you to our witnesses and to all of you who are joining us today. Reporting and documentation protects patients from harm and in some cases will save lives. You may remember at the very first hearing that we held this Congress, we discussed a case where a technician at a New Hampshire hospital infected up to 50 patients with hepatitis C because he was injecting himself with fentanyl intended for patients. Before being arrested in New Hampshire, he had been fired from medical facilities in half a dozen states, including the Baltimore VA Medical Center. The doctor who was fired from the Toma VA Medical Center in Wisconsin for overprescribing opioids and retaliating against employees was immediately hired by a VA Choice Program provider and started treating veterans again. A podiatrist who had been fired from the Togus VA Medical Center in Maine for harming veterans by performing surgeries below the clinically acceptable standard of care was hired by private providers. This same podiatrist harmed other patients after leaving the VA. And GAO found in its report that a provider under contract to provide care at a VA medical facility was fired for patient abuse after 2 weeks on the job. The VA facility terminated the contract, but did not report the provider to the National Practitioner Data Bank or the appropriate state licensing board. In all of these cases, the VA should have reported these providers to the National Practitioner Data Bank and to state licensing boards. VA and medical facilities all across the country are failing to protect patients by not reporting providers who do not meet clinically accepted standards of care. GAO found that providers who should have been reported were able to continue practicing at the VA during professional practice evaluations and reviews, and even after being fired from VA or forced to resign. I would like this hearing to examine what the VA can immediately do to ensure incompetent and unprofessional providers are reported, and whether legislation is needed to ensure that this reporting happens and that patients are protected. Additionally, GAO's report raises 2 issues that we continue to observe in our subcommittee hearings: unclear and confusing VA policies and lack of oversight from the VISNs. The GAO found that both unclear policies and lack of VISN oversight contributed to VA's failure to report providers to state licensing boards and National Practitioner Data Bank. This week, Congresswoman Brownley and I asked the GAO to study the role of VISNs and to help us determine whether VA policy appropriately outlines the VISN's oversight responsibilities. We have heard countless times on this subcommittee that VISNs are not conducting appropriate oversight. When the GAO completes its work, I'd like our subcommittee to hold a hearing to determine what action should be taken to ensure that VISNs are enforcing VA policies and performing their oversight duties. I also remain concerned about unclear VA policies and directives. This is one issue that has contributed to VHA's placement on the GAO high-risk list, and confusion over VA policies on reporting providers to state licensing boards and the National Practitioner Data Bank was a major cause of VA's failure to report. VA employees should not have to read multiple policies and outdated directives to figure out which policy should be followed. Policies and directives should be clear, easy to follow, and policies should be clearly communicated to medical facilities. Employees who fail to follow policies should be held accountable. Finally, providers who are fired from VA for failing to provide quality care to veterans should not be treating patients as a choice program provider or receiving taxpayer dollars. Now, Senator Tammy Baldwin has a bill that has passed out of the Senate called the Access Act. It would prevent fired or suspended providers from treating veterans. It passed recently in the Senate, and I'm hoping that our VA committee will quickly bring this bill to the floor and send it to the President's desk, and I look forward to working with the Chair and Chairman Bergman to that effect. Thank you, and I yield back.
Thank you, Ranking Member Custer. I ask that all members waive their opening remarks as per this committee's custom. With that, I invite the first and only panel to the witness table. As I see, you're already comfortably seated, and I think you know that you have to turn your mic on. And other than that, nothing else has changed since the last time you were here. On our panel, we have Dr. Gerard Cox, Acting Deputy Undersecretary. You know, we need to shorten up some of these titles. For Health, for Organizational Excellence for the Department of Veterans Affairs. He's accompanied by Dr. Sharif Elnahal, VA's Assistant Deputy Undersecretary for Health, Quality, Safety, and Value. We also have Mr. Randy Williamson, Director of Healthcare Issues for the Government Accountability Office, and Dr. Hank Chowdhury, President and CEO for the Federation of State Medical Records. I ask the witnesses to please stand and raise your right hand. Do you solemnly swear, under penalty of perjury, that the testimony you are about to provide is the truth, the whole truth, and nothing but the truth? Thank you. Please be seated. Dr. Cox, you are recognized for 5 minutes.
Thank you. Good morning, Chairman Bergman, Ranking Member Custer, and members of the subcommittee. Thank you for the opportunity to discuss our medical center's clinical competency reviews, compliance with reporting to state licensing boards and the National Practitioner Data Bank, and the related GAO report. I'm accompanied today, as you noted, by Dr. Sharif Elnahal, the Assistant Deputy Undersecretary for Health for Quality, Safety, and Value. Prior to joining the Veterans Health Administration a little less than 4 years ago, I served for more than 30 years in uniform as a U.S. Navy medical officer. I'm a proud veteran of the 1990-91 Gulf War and the ongoing conflict in Afghanistan. I dealt firsthand with issues surrounding clinical competency and adverse privileging actions as the commander of the Naval Hospital at Camp Lejeune, as the second in command of the U.S. Naval Hospital in Okinawa, Japan, and as the deputy to the medical officer of the Marine Corps. During my last year on active duty, I was served as the Assistant Inspector General of the Navy for medical matters. In my capacity at VHA, I'm responsible for strengthening our compliance, ethics, and oversight functions, and I assumed broader responsibility as the Acting Deputy Undersecretary for Health last month. Therefore, I know well how important the issues we'll address at today's hearing are to VA and to my fellow veterans. VA has an ethical and moral obligation to our veterans, our agency, and our community to report certain providers to the National Practitioner Data Bank and state licensing boards. We're taking 3 major steps to improve clinical competency and reporting. Number 1, we're improving our oversight to ensure that no settlement agreement waives VA's ability to report providers to the data bank or the licensing boards. Second, we're reporting more clinical occupations to the National Practitioner Data Bank instead of just physicians and dentists. And thirdly, we're improving the timeliness of that reporting. We're also rewriting and updating our policies in response to the GAO's report. We're constantly striving for improvement in these areas to make sure our veterans receive the highest quality of care which they have earned and deserve. If the clinical practice of a privileged provider raises concerns about the quality of care, VA conducts a review to assess the provider's performance in that area. This is to substantiate if there is a concern related to the provider's clinical practice and to determine the appropriate next steps. If that information that caused the trigger raises a concern of imminent danger to patients, the provider may be removed from patient care by the medical center director until that review is complete. If the review results in an adverse privileging action, such as reduction or revocation of privileges to practice in that facility, The medical center director is the final authority on that decision in accordance with the accreditation standards of the Joint Commission, the entity that accredits all VA hospitals as well as many hospitals in the private sector across the nation. Once the medical center director decides to take a final privileging action, the clinician is afforded a fair hearing opportunity. Clinicians who resign or retire while under investigation must still go through a limited hearing process. Though the National Practitioner Data Bank only requires the healthcare industry to report physicians and dentists when an adverse privileging action is taken or when they resign or relinquish privileges while under investigation, VA is voluntarily expanding the range of clinical occupations that we will report. We're doing this because we feel it's the right thing to do for veterans. This means that we will report to the National Practitioner Data Bank all privileged providers for adverse privileging actions, all privileged providers who resign or relinquish privileges while under investigation, and any licensed provider who was terminated from a VA facility for substandard care, professional incompetence, or professional misconduct, thus excluding them from future participation in the VA's community care programs. In addition, at the direction of the Secretary, VA now requires that any employment dispute settlement involving payments of more than $5,000 must be approved by top VA officials here in Washington rather than officials at the local or regional level. We'll expand this review process to confirm the requirement to report the provider to the National Practitioner Data Bank or state licensing boards. Any VA employee who is found to have proposed withholding that reporting will be subject to investigation and discipline. In addition to expanding the types of providers that can be reported, VA will improve the timeliness of both the decision-making on whether to report providers and the process of reporting providers, shortening the time frame of that process. GAO's recently released report made 4 recommendations, and VA has concurred with all of them. In response to these recommendations, VA will rewrite policy to formalize guidance on focused management reviews and will include timeline expectations for those reviews. We'll update the standardized auditing tool to include monitoring of appropriate action taken when clinical care concerns are identified and to include monitoring of timely reporting to the National Practitioner Data Bank, specifically for privileging actions and resignation while under investigation. Mr. Chairman, as I've described, VA is taking 3 major steps to improve clinical competency in reporting: reporting more clinical occupations, improving the timeliness of reporting, and enhancing oversight to ensure that no settlement agreement waives VA's ability to report to the data bank and the licensing boards of states. I'm proud of the health care our facilities provide to our veterans, and VA is committed to upholding that high level of care. Thank you for the opportunity to testify today, and I look forward to your questions.
Thank you, Dr. Cox. Mr. Williamson, you are now recognized for 5 minutes.
Good morning, Chairman Bergman and Ranking Member Custer. VA medical centers are responsible for ensuring that their providers deliver safe, high-quality care to veterans. If concerns arise about the VA's provider's clinical care, VAMCs are required to undertake actions to review that provider's care and determine whether adverse privileging actions should be taken that restrict or curtail care the provider is allowed to deliver. VAMCs are required to report VA providers for whom adverse actions have been taken to the National Practitioner Data Bank and state medical licensing boards. At the behest of Chairman Rowe and this subcommittee, GAO evaluated VA's processes for reviewing providers' competency at 5 VAMCs across the country and consistently found a variety of disturbing problems with how these processes are being carried out. Specifically, we found that after concerns were raised about the providers, required reviews of their clinical care was frequently not done or not conducted in a timely manner. Moreover, where adverse actions were taken against providers, VAMCs did not report providers to the data bank or to state medical licensing board as required, or did so in a timely way. We found that during the 4-year period ending March 2017, the 5 VAMCs we reviewed collectively required clinical reviews of 148 providers after concerns were raised about their care. For almost half these cases, VAMC officials could not provide documentation that the reviews were actually conducted. We also found that reviews were not always timely. We found 16 cases where reviews were delayed more than 3 months, and in some cases years after concerns were raised. For 2 providers, reviews were initiated 3.5 years after concern was raised, and then only after we requested documentation on those cases. Bottom line, VAMCs have been lax in conducting these reviews, and VHA has no policy governing how soon reviews should occur after clinical care concerns have been raised. That needs to change. We also found that for providers who had adverse actions taken against them or who had resigned or retired during the adverse action process, VAMCs failed to report them to the data bank and State Medical License Board as VA policy requires. From our sample of 148 providers, we found that VAMC should have reported 13 providers to the data bank and the state medical licensing boards. They reported only one of the 13 providers to the data bank and none to the state licensing boards. VAMC staff told us they were often confused about their reporting responsibilities, even though VA policies are clear in this regard. At one facility that accounted for 6 unreported providers, VAMC staff that were responsible for reporting were not even aware of those responsibilities, even though those responsibilities were actually in the local medical center policy. VA's failure to report providers to the data bank or state licensing boards makes it possible for providers to obtain privileges at other VAMCs or non-VA healthcare entities that serve veterans. For example, for 2 providers in our sample whose services were terminated and whose adverse actions were not reported, one subsequently held privileges at another VAMC, while the other belongs to a provider network that provides care to veterans in the community. Even in the one case where we found that VAC had reported the provider, it took 136 days from the time the appeals process was completed to the actual report, far beyond the current 15-day VA reporting requirement. VA has no similar policy specifying how soon a provider should be reported to the state licensing boards after the adverse action process is completed. Generally speaking, the situations I have described were allowed to happen largely because of poor oversight and accountability from top to bottom in the VHA hierarchy. For example, neither the VISN nor the VA central office officials routinely perform any oversight to ensure that reviews are conducted in a timely way. Moreover, VA policy does not require that VISNs oversee reporting to the data bank or state licensing boards. Because of that, none of the VISNs we reviewed did so. While VA has agreed with our recommendations and promised to make needed improvements, we believe that immediate, decisive actions are needed to remedy the serious problems we identified. Otherwise, VAMCs are potentially putting veterans in harm's way by exposing them to substandard and unsafe care. That concludes my opening remarks.
Thank you, Mr. Williamson. Dr. Chowdhury, you are now recognized for 5 minutes.
Thank you. Good morning, Chairman Bergman, Ranking Member Custer, and members of the committee. Thank you for this opportunity to discuss the important role that state medical boards play in the protection of the public and how, working together, we may be able to better protect our veterans. I'm pleased to mention that I served 14 years in the Air Force Reserves, trained to be a flight surgeon, and have more than a passing familiarity with issues related to healthcare needs of military personnel and veterans. My organization, the Federation of State Medical Boards, was founded in 1912 and represents all 70 of the state medical and osteopathic regulatory boards in the United States and its territories, including Puerto Rico, Guam, the Northern Mariana Islands, the U.S. Virgin Islands, and the District of Columbia. The mission of the FSMB is to support its member boards as they fulfill their statutory mandate to protect the public's health, safety, and welfare through the proper licensing, disciplining, and regulation of physicians and other healthcare professionals. In addition to licensing physicians, state and territorial medical boards are empowered to investigate complaints or reports about physicians who may be incompetent or acting unprofessionally, to discipline those who violate the law, to work with local and federal law enforcement where appropriate, to conduct physician evaluations, and to facilitate rehabilitation of physicians when appropriate. All of our member boards engage in an ongoing cooperative effort to share medical licensure and disciplinary information with one another by regularly contributing data to the FSMB's Physician Data Center, a comprehensive data repository that contains information about more than 950,000 actively licensed physicians in the U.S., including those who work for the VA. The FSMB applauds the noble mission and dedication of the VA and its many personnel in serving the nation's 9 million veterans, and we believe strongly that veterans deserve the same level of quality health care and regulatory oversight and accountability that is available to the general public, if not better. We read with great concern the October 11 investigative story in USA Today. While we are pleased that the VA, through FSMB's Physician Data Center, has had access over a number of years to comprehensive licensure and disciplinary information about physicians who work for the VA, more needs to be done to improve the sharing of information from the VA to the state medical boards that would expediently and efficiently identify unsafe providers operating within the VA system. While the dearth of timely information sharing from the VA is not unique to the VA, civilian hospitals, health systems, medical directors, employers, and all physicians and healthcare providers can and should do more and do a better job of sharing concerns about incompetent or unprofessional doctors. We note that the VA has had policy in place for more than a decade specifically requiring such sharing. In consultation with several state medical boards, we have confirmed what has been reported by the GAO, that the VA does not always alert state boards in a timely fashion about violations, disciplinary actions, or suspected violations of a state's Medical Practice Act. While the VHA handbook outlines notification requirements, in practice, the state boards tell us, many VA sites have not adhered to these standards. While it is important to note that each state board's relationship with their local VA facilities tends to vary, and some are a little better than others in terms of information sharing, we have found it rare for a board to receive upfront or helpful information from the VA in a timely manner. When information is shared with a state medical board, we have learned it is often well past the 100-day notification requirement designated by the VA. These gaps in communication between state medical boards and the VA are of significant concern to the FSMB, and we sincerely hope that we can work with our boards, the VA, and Congress to address this issue and overcome any perceived impediments. Providers who are unqualified or unsafe to practice medicine in the VA should not be allowed to practice outside of or elsewhere in the VA, nor should such providers be able to conceal their disciplinary actions with secret settlement arrangements. Proper notification of provider disciplinary proceedings within the VA to the appropriate state medical boards and the National Practitioner Data Bank will help ensure that unsafe and dangerous physicians are identified and prevented from also treating patients outside of the VA. The FSMB commends Congress for recognizing these deficiencies and for moving swiftly to rectify them with legislative solutions. The FSMB has endorsed H.R. 4059, introduced by Chairman Rowe, House Republican Conference Chair Kathy McMorris Rogers, and Congressman Bruce Poliquin, as well as S2107, introduced by Senators Dean Heller and Joe Manchin. Chairman Bergman, thank you for the opportunity to testify before the committee today. I look forward to responding to any questions you and the other members of the committee may have.
Thank you, Dr. Chowdhury. The written statements of those who have just provided oral testimony will be entered into the hearing record. We will now proceed to questioning, and just know that when Ms. McMorris Rogers comes, we're going to recognize her without objection because she has a real tight schedule, and if everybody's okay with that, you know. But anyway, so we will now proceed with the questioning, and I'd like to recognize Ranking Member Custer for 5 minutes.
Thank you, Mr. Chairman, and thank you to you all for your testimony today. I want to turn my attention to Mr. Williamson from the GAO, and I just want to say for the record that Mr. Williamson is coming up on his retirement after 50 years of public service, 50.
Thank you.
We thank you. On behalf of Americans everywhere, thank you for your service to your country. We're very grateful. In your report, you recommended that the VHA establish timeliness standards for reviewing providers after concerns are raised about their clinical care. And I first want to clarify and then ask what your recommendations, between your testimony and Dr. Chowdhury, I heard 15 days to report, and then I heard 100 days to report. So these may be reporting different things, but if you could just give us an overview of what the current rules as you understand them are and what your recommendations are for timeliness of reporting.
Once a concern is raised, there's no time period for when that review of the provider's care should start. But once that process is started and it is completed, let's say it's completed with an adverse action, then VA has 15 days by their own standard to report to the National Practitioner Data Bank. For state licensing board reporting, the process is different, and it's a lower bar because the state licensing board does their own investigation. VA doesn't have to go through the rigor that they do with an adverse action. So, and there is no reporting requirement at all there. So what we are thinking is that, first of all, there should be a time period or a requirement for how soon after the care is questioned to when the actual review starts. And I see no reason why that shouldn't be 30 to 60 days. We saw nothing in our discussions with VAMC staff that would indicate there were any problems with that. Once reporting in the 100 days, the 100-day requirement, or it's not really a requirement, it's something that VA officials suggest that the state licensing board process should take. But that's not a requirement right now. But so I think basically 30 to 60 days to start the review for the state licensing board, 100 days perhaps to do the review, and then it should be immediately reported.
All right, that's very helpful, thank you. And in your report, you mentioned that VHA has established a required time frame for completing reports to the National Practitioner Data Bank. Okay, this is what you've just reviewed, but not to the state licensing boards. Would you suggest to us that these timelines that you've recommended should be by statute, or should we be working with VHA? It sounds from Dr. Cox that they are making some progress in this regard. Do you have a preference?
Well, if VA established that in policy and was specific enough along the lines I just talked about, that would probably be sufficient. My question would be whether VA is willing to do that.
So then I'll turn to Dr. Cox. Can you clarify for this committee whether new guidelines with timeliness standards are underway, or whether our committee should follow up with statutory guidelines so that after your good works are done, future people at the VA would comply?
Yes, thanks, Congresswoman. They are underway, and our new procedures are being written. In our response to the GAO, which they accepted in response to their recommendations, we committed to giving interim guidance to our field facilities next month in December, and then the process of writing the formal policy and getting that approved and signed will take a little bit longer, but it'll be completed this year, this fiscal year.
And my time is shortly up, but can you just briefly say the timelines that you are suggesting?
The timelines are, as Mr. Williamson said, a recommendation for 100 days to complete the entire state licensing board reporting process. The National Practitioner Data Bank reports generally take much longer because, as was suggested, they require a more thorough investigation and a final decision about whether an adverse privileging action should be taken. So that will be a longer.
My time is up. Hopefully one of my colleagues will follow up. Thank you. I yield back.
Thanks, Ranking Member Custer. Ms. McMorris-Rogers, thanks for joining us this morning. You are recognized for 5 minutes. We know you have an extremely tight schedule.
Well, thank you, Chairman. I appreciate the opportunity to join the Veterans Affairs Committee on this important issue. I wanted to ask Dr. Cox that you testified that the VA is implementing new policies in light of concerns raised about the VA's processes for reporting safety and quality concerns. I remain worried that VHA's central office remains too disconnected from the field to effectively enforce policies. The question is, what specific actions will VHA take moving forward to improve communication with and oversight of the field offices in regards to reporting safety and quality concerns?
Well, thank you. The key to your question is, in fact, oversight. And as Mr. Williamson has pointed out, as GAO has pointed out to us before, as Representative Custer mentioned in her opening remarks, The VA has come under criticism for not providing adequate oversight and accountability of its facilities, and I share that concern. That is one of the reasons that we're on the GAO high-risk list. So we need to do much better. I mean, I can't excuse the fact that in the past, that adequate oversight by VISNs and by the central office has not been provided. So among the steps that we're taking are developing a new electronic auditing tool that we'll be able to use and will require the VISNs to use to monitor the timeliness and the compliance with reporting requirements within the facilities in their regions. And then we'll be able to compile that information at the national level beginning in 2018 and be able to generate a report at the end of the year so that we'll have a much better handle on how things are going out there.
So that's part of the solution. But I think, as we know, reaching agreements to exchange refraining from reporting a provider for their resignation or retirement are against VHA policy. And concerns persist that these agreements are still taking place. So what will make oversight of these policies change the outcome?
You're absolutely correct. Any agreement that involves negotiating a decision not to report somebody who should otherwise be reported is not only a violation of VA policy, it's illegal and it's unethical. And when we find that any facility director or other leader in the field has engaged in such a negotiation, we will provide appropriate investigation and take disciplinary action as warranted.
What are you doing with the current cases that we've been made aware of?
Each of those cases has been provided to us. The GAO was able to give us the names of the individual providers who were not reported in a timely fashion and that they cited in their report. And so we now have that information and have begun the work of contacting each of the facilities that are in question, determining why what happened did not happen, and have already begun the process in all of those cases, 9 out of 9 now, to conduct reporting both to the data bank and to the state licensing boards.
How long do you anticipate that taking?
Well, 4 of those 9 have already been made. 4 of those 9 reports have already been made. Those were the simpler ones where the individual left VA's employment while under investigation, so it's a fairly easy decision. In the other 5 cases where there was an adverse privileging action taken, there's a little bit more process to make sure that the individual has a chance to rebut the claims and so forth, but once that process is over, the reports will be made very quickly.
So can you just share with me what will be the role of the VISNs in this implementation?
VISNs need to do a better job of overseeing these practices within their regions. There, in my view, is a long-standing lack of clarity about the roles and responsibilities of VISN officials vis-a-vis their facilities and also vis-a-vis the central office. So great discussion is going on now across VA and in parts of the organization that I work about clarifying those roles and responsibilities. You may have heard that Secretary Shulkin is committed to modernizing the VA, and this is one of the key elements of the VA modernization effort, to clarify the decision-making authorities, the roles and responsibilities, and then to hold people accountable for maintaining those responsibilities. Mm-hmm.
Well, I greatly appreciate your attention to this issue. I appreciate so many that work at the VA all across the country, but unfortunately we've also had some incidences at the medical centers that I represent where doctors were let go, but then it wasn't reported anywhere, and then they went into the private sector. So it's very important that this accountability take place. So thank you, and thank you, Mr. Chairman, for giving me the chance to join you today.
Thanks for joining us. Now going to recognize Mr. Takano for 5 minutes. Thank you for joining us.
Chairman Bergman, I want to thank you and Ranking Member Custer for letting me join the subcommittee this morning. I really appreciate what you have done. Dr. Chaudhry, VA has a policy of requiring the reporting of providers. Do other hospitals and medical directors, physicians, and health systems have policies requiring the reporting of incompetent or unprofessional providers?
Congressman, you're referring to outside the VA
Outside
system?
the VA.
There is a requirement understood but not always followed by hospitals and others to medical centers and facilities to share information as well. I made it a point in my remarks to mention that this issue is not unique to the VA. The state medical boards can do more for the nation in protecting the public if they had access to more timely information from all sorts of sources. And I agree with Dr. Cox, it is an ethical matter ultimately for physicians and others to do that as well.
So, but these policies vary from state to state. And I'm trying to get a sense, the line of my question is to try and get a sense of VA and non-VA providers and the accountability that we expect and the reporting of these incidents. Do you have any data that could be used to compare the rate at which VA providers are reported to the rate, compared to the rate at which private providers are reported to State Licensing Board and the National Practitioner Data Bank?
Yes, I can provide you, my staff can provide you that information afterwards.
Okay, I'd be very interested in seeing that. What review mechanisms are afforded to providers before their license or practicing privileges are suspended or revoked?
Just as in the VA system, Congressman, there is a due process that the state boards adhere to as part of their medical practice acts. So any physician for whom there is a complaint, there is a process to determine if it warrants an investigation, number one, and if it does, there is ample opportunity for the physician to be represented by counsel if necessary and to be able to rebut or explain the circumstances. These processes are not new. They've been around for the state boards for decades, and they ultimately serve the public in the right way, we believe.
How could the VA make its provider reviews and professional performance evaluation processes more transparent to veterans, state licensing boards, and to the public?
Well, one of the things we've heard, Congressman, is that the information that the state boards do get sometimes has significant pieces of information that is redacted for privacy purposes, and sometimes even the names of the providers. It's very difficult to do the right thing at the state board level if information that's relevant to the complaint and the individual is not made available. So while we're talking about sharing of information, I would hope that that information is actionable information.
Getting back to the question about the comparative data, are there any generalizations you can just sort of tell me? I mean, is the VA on par with the non-VA providers in terms of its reporting practice, or is it is the private sector ahead? How do they compare? Is there any? Or is it just too complicated to explain in a short answer?
I couldn't tell you that, but what I can tell you is the VA has a benefit of being a centralized system. It's a closed system, so that in theory, when something goes wrong, it should be able to be traveled up and to be addressed in the right way. The nation's hospitals are all under different management. Some are for-profit and non-profit. It becomes a little bit more complicated, but there's a benefit to the VA to be able to do this in the right way.
Yeah, I'm generally interested in the question as to, the VA is certainly subject to the oversight of the Congress, of this subcommittee, and I think it's important for the public to understand how transparent the private systems are too. I kind of get the sense that they're less transparent because they don't report to Congress and they're not subject to the kind of oversight that we can lend, and if there's comparable kinds of oversight at the state level.
I couldn't tell you if they're less compliant or less forthcoming. What I can tell you is the FSMB last year through our House of Delegates, which is made up of all the state licensing boards, passed a resolution about the duty to report, which speaks to what Dr. Cox was referring to, the ethics of this. It is important for everyone, not just providers, but members of the public, members of Congress, and others, that if they're aware of an issue, whether it's individuals or an entity or a site, that they need to speak up.
Dr. Cox, how will the VHA hold VISNs accountable for performing routine oversight over medical facilities and ensure reporting to state licensing boards and National Practitioner Data Bank?
Well, as these policies are revised and the requirements strengthened, we'll be able to hold VISN officials more accountable. I think that the importance of reinforcing our expectations of them has to come first, and then as soon as those expectations are made clear, we'll be able to address that.
All right, thank you very much. My time is up, and I want to thank the chairman and ranking member again for allowing me to participate today. Thank you.
Thanks, Mr. Takano. Mr. Bost, you are recognized for 5 minutes.
Thank you, Mr. Chairman. A lot of the questions that I had have been answered, but I wanted, and I know we're moving forward with a different policy, but Dr. Cox, can you explain to me, because I'd like to know, How in the world anyone ever in the VA process thought it was okay to make a deal to send somebody on to a different location and or just not report them, have them leave. Whenever I have my constituents out there, all of a sudden they go into the private sector or whatever, and then we've endangered them as well. How did that come about?
Well, Congressman, I agree that's a very troubling situation, and I can't explain how that comes about. As you know, each of these negotiations is conducted on a case-by-case basis, and there are different facts that pertain. I will point out that when we're talking about settlements of employment disputes, that's separate from the credentialing and privileging actions taken by medical staffs to police themselves. So these are negotiations that occur because our VA providers happen also to be federal employees and subject to all the processes and responsibilities that go along with that. So those settlement agreements are generally undertaken by people outside the medical staff, but that's certainly no excuse. And as I said before, once we determine that any such agreement has been made that is not only a violation of policy but illegal and unethical, then we will take action to investigate those individuals.
Let me tell you a story, and many of my colleagues have heard this. Prior to being elected, I actually, because I have a VA close to my home, I actually asked many people online to give me any information. A very good friend of mine actually responded back that actually we had a physician at the VA hospital in Marion. He said that she did a great job of his exam and everything like that. However, if she didn't have religious beliefs where she couldn't look below the waist, they'd have found his hernia. It took us almost 3 years to get rid of that physician. 3 years. Now, when she took her medical course, she didn't have that religious belief. Okay, this was picked up afterwards. Do we have things in place now that allow the administrators of VA, when a situation like this comes up, that they can actually remove them from their position so that someone that can do their job adequately can be put in place? Or are we bound by certain rules that they are protected where you can't let them go?
Congressman Boston, I'm going to defer to my colleague, Dr. Elnahal, to help answer that question.
Congressman, I think it's a great question. And in that particular case, we do have a process within the VA that allows us to evaluate the clinical behavior and practices of physicians. It's called a focused professional practice evaluation. So if there is a clinical concern raised, or if somebody notices that something was missed for a reason like that, there is a process by which we evaluate through a peer who also practices in that specialty, and people who know how to, the standard of care and the scope of practice to evaluate that practice. And in that situation, if that was caught in such an evaluation, something would have been done about it. The concern would have been raised to the Chief of Staff and potentially a privileging action.
Has that policy been in place a long time?
We've been doing focused professional practice evaluations for a very long time.
Okay.
Every time we onboard a new physician, that is done just for our due diligence, and then it can also be done if a clinical concern is raised.
Okay. More on a personal note before my time runs out, specifically with Marion, and Dr. Cox, you may have to look this up and get back with me later on it, but we actually, there was the OMI did a report and found out that many of our radiologists were either over or under reading reports, and it was then turned over, and I just need to know if the review has been done on that, and has that problem been corrected?
The Office of the Medical Inspector, which I oversee, has actually been to Marion twice in the last few months. The first time for the radiology service evaluation that you mentioned, and the second time to look at broader issues of patient safety and leadership and so forth. So the findings of the review of the radiology department have been made complete, recommendations made for corrective action, and the facility has provided its corrective action plan to us, which we are monitoring to completion.
Okay, thank you very much. I yield back.
Mr. Poliquin, you are recognized for 5 minutes.
Thank you, Mr. Chairman, very much. I appreciate it. Thank you all for being here. Dr. Cox, first of all, thank you very much for your service to our country, and everybody else on the panel, I really appreciate it. Dr. Cox, you are a physician.
Yes.
Okay. Is the standard of care at the VA the same standard of care that you should receive, or a patient should receive at a non-VA hospital?
Absolutely.
Okay. You know, I'm really troubled by what I'm hearing today and by some of the news reports that I'll get into in a little bit here. We hear from Mr. Chaudhry that folks in the non-VA medical center community, whether it be a for-profit or non-for-profit, seem to report on a more timely basis when we have accusations or allegations or investigations about malpractice, but they're not as forthcoming at the VA. Didn't I hear you say that, Mr. Chaudhary?
Part of the problem, sir, Congressman, is that the state medical boards are complaint-based, so that we don't know what we don't know. So I couldn't make comparisons, but it's an issue of reporting everywhere.
Okay, so let's take a look at Mr. Williamson. You've been around for a long time.
Yeah.
Congratulations on your forthcoming retirement, sir. You looked at 5 out of the 170, roughly, medical centers in the VA during this study of yours. And you identified about 148 doctors and nurses and what have you, and practitioners that were that the concerns rose to the level of being investigated. And only one of those, if I'm not mistaken, was reported to the national database. Is that correct? But not to the state.
That's correct. That's
at the state level. Okay. And it took 4.5 months to do this, roughly.
Took what?
4.5 months to do this, roughly, right, 136 days. Okay, do you find that unusual?
Yes.
Okay. If you were to do the same evaluation of 5 out of the thousands of hospitals in the non-VA space, would you think you'd find that sort of mismanagement?
Probably. I don't know, but, you know, I can tell you that if we looked at, I'm confident I could take my audit team in almost any VA medical center and find similar to things that
okay, I'm talking about if you were auditing non-VA hospitals.
Non-VA hospitals, I have no idea on that.
Okay, here's one of the problems that I have, folks. There's a terrific veteran from Maine. His name is Jake Myrick. Jake was an infantryman in the Army for 15 years and discharged in 2003. In 2004, he goes up to Togus, which is our only VA hospital in the state of Maine. First in the country, by the way, we're very proud of. And for the most part, they do a good job. In 2004, he meets with a fellow named Tom Francini, Dr. Thomas Francini, who's a foot surgeon at Togus. He's having a lot of problems with his foot. And in 2005, Francini operates on him and botches the operation. For the next 5 years, the pain is excruciating, doesn't fix the problem. They say, well, you need some orthotics or you need some ankle braces. He stops running, stops biking, stops coaching his kids in athletics because he just can't take the pain. He's depressed, he's at home, quits his job. Now, during the ensuing 5 years, while all this is happening from roughly 2005 to 2010, there are 87 other veterans that are operated on by Mr. Francini up at Togus. 87 other, all botched over this 5-year period. One of them, April Wood, had multiple operations on a problem ankle that were botched. The pain was so excruciating, the only way to relieve it was to amputate her leg. Amputate her leg. Now, in 2010, the folks up at Togus, and confirmed by the headquarters of the VA, wherever the heck that is dealing with this issue, recognizes, you know, absolutely, there was a problem here. In 2010, 5 years after. It took them 3.5 years to get back to those 88 folks who suffered under Mr. Francini to even notify them that, yes, he was the problem, and it exceeded the statute of limitations. You know what I think? I think we got a culture here at the VA. No one wants to be responsible. You're not reporting on time to make sure no other people are hurt. I think you're all protecting your butts. That's what I think's happening. This mismanagement is breathtaking. How do you fix it? I don't know how to fix it. I got a great idea, though, Mr. Chairman. And I don't know if there's a way to do this, but I'm going to talk to David Shulkin about that this afternoon. Maybe there's a way we can withhold funding from VA Central to some of the hospitals out in the field who don't report on time what they should report so this doesn't happen in the future. Maybe we can do something like that. I don't know if we can, but I'm going to find out. Secondly, and thank you for the indulgence, Mr. Chairman. H.R. 4059, I have co-sponsored with Chairman Phil Rowe and Conference Chairman Kathy McMorris-Rogers, who was just here. It requires the VA to do what they're supposed to do. Why in the heck do we have to write a new law to force the VA to abide by their own rules? And we wonder why the American people are losing confidence in government? These are people who fought for our country. These are veterans. We got a problem at the VA with people providing service to our veterans with botched operations, one after another, and we're not reporting it on time, and they go out and they do it to someone else. Yeah, I'm all for withholding money from these folks that don't report this. But it is a shame, Mr. Chairman, we have to pass legislation to have the VA follow their own guidelines. I yield back my time.
Thank you. Dr. Dunn, you are recognized for 5 minutes.
Thank you very much, Mr. Chairman. Gentlemen, when physicians usually come up here to testify, it's usually a happy occasion for me. We get to, you know, I think I'm a surgeon myself, we view the world through the same prism, and so we're often, you know, able to agree on many things. I think today we're faced with a problem, though, that's a disturbing pattern of bureaucratic ineptitude and cover-ups. And I should note here at this point to Dr. Cox, I think you're new to the VA, am I right? You're brand new?
Relatively new, yes, sir.
Yeah, okay, so the Deputy Undersecretary for Organizational Excellence, as I understand?
Well, that's a role I assumed in an acting capacity last month.
Okay, so that's the role that I see. I see you you Google you under. So you're sort of the new sheriff in town, supposed to come here and drain the swamp. Is that right?
I suppose you could characterize it that way.
Well, that's the most charitable way I think I can. So, you know, we have some hard questions we have to face. And I'm going to refer to a specific VA medical center that's just outside my district in Florida. The Bay Pines VA Center has indefinitely suspended thoracic surgeries after being notified by the Joint Commission of issues within that department with at least 3 veterans dying from complications following surgery. So in August of this year, the VA Office of Inspector General found deficiencies in the process of evaluating the competency of the thoracic surgeons at Bay Pines. How did those problems within the thoracic surgery department persist after the VA claimed to have corrected those problems?
Congressman, I'm going to have to admit I'm not familiar with this situation at Bay Pines specifically, but I will certainly review the OIG report, and I'd like to take your question and get an answer back to you if I may.
We have a report that there's another entity doing an external review. Do you know anything about who that entity is?
No, I'm not sure.
So you can't tell me whether or not that's somebody from within the VA or outside the VA altogether?
I can tell you that I'm not familiar with any internal investigation going on at Bay Pines.
In your testimony, you said that the VA's clinical reviews consist of providers from the same specialty objectively reviewing patients that the provider had seen previously. However, from Bay Pines, we have an administrative psychiatrist conducting an ongoing professional evaluation of a thoracic surgeon. Can you tell me how that would happen, or how, if you think that that has any basis in occurring even?
I can tell you that that certainly wouldn't represent a peer by my definition, a psychiatrist reviewing the clinical care of a thoracic surgeon. And so I'm not sure how that would have happened. Now, you said administrative review.
That was disturbing for me as a surgeon to see that, honestly. I think that that's clearly, you know, below the standard of medical practice. Are the professional evaluations, these focused professional evaluations ongoing, are they standardized throughout the VA system?
No. Focused professional performance evaluations are conducted and customized at each facility, and in fact within each service to the particular needs of that specialty. So these are, first of all, these are not unique to the VA. FPPEs are part of the Joint Commission's accreditation standards for monitoring clinical care, and they are prospective in nature. So these are put into place when a provider has an issue that's not egregious, where there's no imminent threat to patient safety, but where closer monitoring is required to ensure that they're practicing high-quality care. So the particular criteria for that individual in that specialty and the concern about their care goes into crafting an FPPE that is addressing that situation.
So I've been party to a number of these over the years. I've been chief of surgery at several hospitals over the years. And I can tell you that we would always have specialists of the same specialty participating in those ongoing reviews. And so I have some familiarity with that. And I found it appalling the way this one was carried on. What do you do, what does the VA do when there's only one provider of a specific specialty, urologist, thoracic surgeon, whatever? How does that center handle that problem?
And that's a great question, because as you know, there are many smaller VA medical centers, some located in rural areas where there is only a sole
and
provider.
Shortages throughout the system.
Indeed. So ordinarily, if you need to have a peer of the same specialty review the clinical practice of a sole provider at a facility, then the VISN will arrange for another member of that same specialty from another nearby medical center to conduct the review.
So our time's drawing short here. I just want to say that I think you have a very hard job. I don't envy your job, but we will help you here on this committee. We want the VA to improve. We need it to improve. You know, failure is not an option. You know, we're going to give you the help you need to do this, but, you know, we have to have a better VA medical system when we come out the other end of this. Thank you very much, Mr. Chairman. I yield back.
Thank you, Dr. Dunn. Mr. Arrington, you're recognized for 5 minutes.
Thank you, Mr. Chairman. Thank you, panelists. When I think I can't be more depressed about the VA's lack of oversight and accountability and their fundamentally flawed organizational management, then I have this hearing, and so I got sink to new lows because it's just shameful. This is why I'm for choice and competition, and quite frankly, we could do well just to outsource the whole thing, because we have trapped our veterans in this system. Trapped them. They don't have any way out. My colleague, Mr. Takano, asked a really good question about the difference between private performance, nonprofit, and the VA. The difference is when they find out, and Mr. Chaudhry, you know this, and you interact with all sorts of hospital systems, when they find out at a private or nonprofit hospital that somebody has been sanctioned or disciplined and not reported and continues to practice, they lose patients, which means they lose revenue, which means they'll be insolvent. But the VA keeps getting paid. They get their paychecks regardless of how they treat the veterans, because they have a monopoly over them. It's a single-payer system, and they're trapped, and it's shameful. Now, Mr. Cox, you said it's a moral and ethical obligation to make sure there's an environment where the veterans, our veterans, are being cared for by the best of standards, professionalism, competency, et cetera. I agree with that. But clearly, that doesn't exist. How long has it not exist, Mr. Cox, that VA has fulfilled its moral and ethical obligation to care for our veterans? How long has that existed?
Well, I'd like to respond by saying that even though our salaried physicians and other providers in the VA are part of this closed system that you talked about, it is still our obligation to ensure that the same quality standards apply as we apply in the private sector, in the military health system, and everywhere in American medicine.
But 8 out of 9, this is the majority of clinicians in the GAO report, 8 out of 9 were not reported when they had problems, when they had adverse action taken. 8 out of 9. You're almost 100% at not reporting. That's not an ethical, meeting your ethical or moral obligation. So it's devoid of that right now. You were the medical, what do you call it, the medical inspector, like the inspector general, but for the VHA? How many years were you in that role?
I was the interim medical inspector for a little over 2 years.
2 years. When did you first learn that this was a problem, this lack of oversight and accountability, and just almost no management of this process of making sure we had the good guys still practicing, the bad guys weren't, and that we communicated with others to make sure the bad guys didn't practice somewhere else and hurt other patients? How long have we known about this?
Well, I became specifically aware of the issues with reporting to state licensing boards and the National Practitioner Data Bank when the GAO did its audit.
What about your own internal, though, controls and knowing that this wasn't happening? Was it the GAO report that revealed this to you, or did you know this? Did you ever conduct an investigation or some review or audit as the Inspector General for the VHA?
No, this was not something that was the subject of an internal investigation or audit, but that points out the need for us to strengthen our internal audit capabilities, and we are in the process.
Do you have family members, a spouse, children?
I do.
Would you allow your wife or your children to go to a healthcare system knowing what you know about this process and how flawed it is in this area?
I'd feel confident with my family members going to a healthcare system that has solid policies in place and that enforces them.
Well, but we're not enforcing them, right? Correct?
That is correct.
And we're not creating we're not fulfilling our moral and ethical obligation. So the question is, in a situation like that, would you allow your family member to go into a healthcare system like that?
I would want to feel confident that the healthcare system not only...
I don't mean to put words in your mouth, but you wouldn't do it, okay? You wouldn't do it, because it's not happening. And Chaudhry, you wouldn't do it. I don't even know your family. I know you wouldn't do it. Nobody on this panel would allow their family members to be trapped in a situation like this when we're talking about their very lives at risk. These are people that deserve the very best, and we're giving them the very worst in our efforts to make sure they're taken care of. Has anybody, Mr. Cox, been fired for these, or disciplined for this problem as it's been revealed in the GAO report?
Well, as was mentioned before, we now know the sites, and we now know the providers who were uncovered in the GAO's audit, and so we are undertaking appropriate review of their work, investigation of their decision-making, and disciplinary action as necessary.
Mr. Chairman, I'm going to yield back because, out of respect for my colleagues' time, I'd love to have some follow-up questions if there's time at the end of this. But I would ask that y'all, the VA, submit for the record any disciplinary action that has occurred over the last several years with respect to the medical center directors involving this sort of practice of reviewing and reporting adverse actions. So if you would please get that information to the chairman, I'd like to see that.
We'll be happy to.
Okay.
Thank you, Mr. Arrington. We are going to do a second round here for anybody who has the second question. So, Ms. Gonzalez-Calan, you are recognized for 5 minutes.
Thank you, Mr. Chairman, and thank you, Chairman Rowe, for coming here and sitting here. So I'm between two chairmans. I'm happy today. First of all, thank you for all members of the panel for being here. Just to notice that the five centers that were evaluated, Puerto Rico and the territories, were not part of that study that was conducted by the GAO. One of the issues that I do want to ask is regarding Dr. Cox. I do understand the responsibility to report to the to the National Practitioners Database is from the medical director of the VA, correct?
The responsibility lies with the medical center director, so the hospital director.
And in the absence of that medical director, it should be on the staff, correct?
Well, there will always be somebody performing the role of the medical center director, perhaps in an acting capacity, of which we have many, but it's according to the accreditation.
The responsibility can be delegated to somebody there.
Actually, the decision to report, I believe, cannot be delegated below the level of the medical center director or the person performing those duties. Now, there are certainly clinical experts, right? The chief of staff, the executive committee of the medical staff, the providers who advise the medical center director about when a report may be necessary, but it's the director's responsibility under the Joint Commission's accreditation standards to do so.
But the problems and the report we have here establish that the main issue we got is the misinformation, miscommunication, and even the own staff is unaware of their responsibility to make these reports. And some of the regulations said that they are not, maybe they do not understand the policy and the regulations that come with that appointment. How are you facing that, that problem?
Yeah, it's very troubling that there are apparently medical center directors and chiefs of staff who don't understand the policy or who perhaps don't even know to turn to the central office where the policy originates to ask for help. I'll tell you that there's lots of information made available both by direct consultation and published on our internal website so that anybody knows where to look and find it. And fortunately, these instances are relatively rare, right? So the particular medical center director in the course of his or her tenure may only face these kinds of situations once or twice. Those that perform best are the ones that seek help, that seek consultation with the program office that oversees this, where the true experts reside. And others that don't seek consultation or who try to do it on their own or may misinterpret what are sometimes confusing policies are the ones that tend to make errors.
I do have a problem here, and I do share my colleagues' concerns with this situation in the VA. And what is the consequence for those staff that are not reporting or not taking their duty as they should, and they're not properly carrying out that responsibility? What is the consequence for them directly?
Well, fortunately, under the new Accountability and Whistleblower Protection Act, the Secretary has wider latitude.
But that's the now. Before that, was nothing?
I can't speak to any particular instance, but no, there wasn't nothing. I think, though, that the ability to hold VA employees accountable is greater now, and the Secretary certainly has vowed to do that, to uphold our highest standards.
What should we do in terms of improving that communication, improving that knowledge to the staffers in terms of their responsibility to notify those elements to even the states or the National Practitioner Database?
I agree we do need to do a better job of communicating these requirements and of educating those that we put into leadership positions. As you know, we have many new medical center directors and new chiefs of staff. Some of them, quite a few of them, are acting. And so our pledge is to do more outreach to inform them of these policies and to make available help for them when they face this, again, fortunately, not common situation.
You know that many of our VA medical centers are understaffed, and that's happening in Puerto Rico too, and our only medical VA center. How are you gonna have all those personnel be oriented, educated, and know what they're going to face in terms of reporting this in a properly timed manner?
That's a great question. I think the focus should be on targeting the people in positions that really need to know this.
Are you doing that right now?
Yes. Yes, we are improving our education efforts, as I said earlier, revising and strengthening our policies, and those revised policies will be communicated, and we'll make sure that everybody knows what they need to know.
Thank you. Thank you, Mr. Chairman. I yield back.
Thank you. Dr. Rowe, you're recognized for 5 minutes, sir.
Thank you, Mr. Chairman, and I apologize for being late. I had another committee I had to go to. As a physician and veteran myself, I was really alarmed by the GAO findings, and during my medical career, my colleagues and I took great pride in meeting and exceeding quality standards. And for those of you all who haven't served on a medical staff, what I'm hearing here now is really, Dr. Cox, is a net in the first reader. I mean, this is something that every hospital does. You apply for credentials to the hospital staff. They vet your credentials very clearly, and then you're on the staff and you start taking care of patients. And if there are issues that come up, we have an executive committee or a credentials committee that looks at those things and puts a plan out. I mean, any hospital administrator in the world knows that. Any chief of staff knows that. I find it astonishing that we have to educate somebody who's a medical center director that would be something they needed to know about. Would you please answer that, because I found your statement just then amazing to me, that you'd have a medical center director somewhere that wouldn't know something as simple as that.
Well, Chairman Rowe, thank you for the question. I didn't mean to imply that medical center directors don't know about the procedures for applying to medical staffs, being granted privileges, the vetting that goes on at every VA medical center, just as in every other hospital that hires physicians. So, I mean, those are basic and ongoing processes. What I meant to say is that for the much less common situations where there are concerns about a provider's clinical practice, where there's contemplation of a need to perhaps report them to the data bank or to their state licensing board, that those processes are less familiar, and so we need to do a better job of making sure people are familiar with that.
I would think that, and this was surprised and shocked me also when I read this, that in 5 medical centers, this is only 5 medical centers, the VA has over 150, that 148 providers were looked at, and then when only one was actually, do you know how many in the VA, and this is maybe a question you couldn't answer today, but in the entire system have been either reported to the state licensure boards or to the national data bank?
Well, that's a question that I can't answer completely. Regarding the National Practitioner Data Bank, there are 3 circumstances when a provider...
No, I know those things, but my question is not, that's not the question. I know those. The question is, how many have been from the VA system actually been reported? Because it looked like that, and my concern is this. Look, our hospital's at home. Here's a VA, and right next door is the hospital that I practiced. What happens if VA doesn't do that and someone then comes to our credentials committee, we don't have this information, and we put this doctor on the staff that should not, this provider on the staff that shouldn't have been put on there if we'd had that information. That's the scary part, and that doesn't happen the other way around. That information does go, and every doctor that practices medicine now is concerned about that, their name being in the data bank.
But you're absolutely right. That is the core issue here, to make sure that providers who are not competent or safe to practice are reported properly.
And that didn't happen.
That didn't happen
in this report, and we don't know how pervasive it is because we just did a small sample of the physicians in the VA system. Just 5 hospitals, medical centers.
That's correct.
Well, my commitment to ensuring VA providers adhere to professional standards compel me to introduce H.R. 4059, and Ms. McMorris-Rogers may have already talked about this, Ethical Patient Care for Veterans Act of 2017, along with Mr. Poliquin. And our bill would direct VA to ensure that each of its physicians is informed of the duty to report any impaired or incompetent provider on ethical act that requires reporting. I would think that just should be policy. It shouldn't need a law to do that. That should just be the policy of every VA medical center. We should have some confidence, as Mr. Arrington obviously does not, to carry that out. Would that be reasonable?
It is entirely reasonable, and it is already policy. The problem is we're not enforcing
implementing that
the way
policy
that we need to.
Dr. Chowdhury, for the benefit of all of us gathered here today, would you explain the function of the state licensing board and the importance of VA's communication to privileging actions to state, to communicate those adverse things to a state board?
Thank you very much, Chairman Rowe. The state medical boards play an important function in this country in looking out for the public. Their primary mission by statute at the level of the state and the territory is to protect the public by not only licensing appropriately qualified and trained doctors, but also disciplining them when there's reason to do so. As I mentioned earlier this morning, we don't know what we don't know. It's a complaint-based system, and so it's important for the state licensing boards to have the information from facilities, from providers and others so that they can investigate and allow due process for the physician, but follow through and do what's appropriate, whether it's a letter of reprimand, a fine, a suspension, a limitation, or ultimately a revocation of license, which they do as well.
You know, I think my time has expired, but just one last statement. One of the reasons we have such confidence in our medical system is because of our board system. It allows us to make sure that patients understand when they come in that they're going to get the highest quality of care. And with no information, you're absolutely right. You can't do your job. Am I correct?
Yes, sir.
I'm sorry I exceeded my time. I yield back.
Thank you, sir. I will claim 5 minutes for my time as the chairman. Approximately 1 year ago, a veteran had his leg amputated due to a blockage. This blockage was later determined after the amputation to be caused by plastic packaging mistakenly left in an artery by his VA doctor. We met with the medical center and the visiting director overseeing that facility recently, and they informed us that while the provider is no longer allowed to practice in that VA facility, the doctor still practices in the community. The medical center and the visiting director stated that they could not report this provider's actions to the NPDB or relevant state licensing board because he worked for a contractor, and it was the contractor's duty and responsibility to report that provider. Dr. Cox, or anyone who would like to respond, what prohibits the VA from reporting a contract provider who administers substandard care inside a VA facility?
Nothing. Contract providers are supposed to be reported just like anybody else.
So you're telling us we were lied to?
Yeah.
Okay. Dr. Cox, GAO's report discusses the Focused Professional Practice Evaluation, the FPPE that we talked about earlier. This process, which consists of a prospective review of a provider's care over a specified period of time during which the provider has the opportunity to demonstrate improvement in specific areas of concern. Explain to me how VA can take appropriate action against a provider when these reviews are not properly documented or conducted in a timely manner.
Well, that is a very concerning question, and I think what GAO found is that in many cases there was no documentation that the review had been done. It's not clear whether that means that they hadn't been performed at all or whether the review hadn't been saved in the provider's file as it should have been. So there's another gap there that we need to address and are addressing with our strengthened and revised policy to make sure that facilities understand what seems easily understandable, that when you have paperwork that relates to something as serious as a provider's clinical competence, that it needs to be maintained as part of a system of records and kept in their file.
We also found that not only was documentation missing for almost half, but in 21 cases, the reviews weren't done at all. So it was a combination of both.
Okay, so Dr. Cox, you've been in the seat for a very short period of time. Mr. Williamson, you've been here for 40 years, different with the GAO. So in either case, is it fair to ask either of you, is what we're talking about here today new?
Go ahead.
I'd be willing to bet, and it's only speculation on my part, that these things aren't new and that problems exist in many health systems, including the VA, and have existed for some time. So periodically, we need to reinforce what the rules are, what our expectations are, and that's the situation we find ourselves in.
So how do you plan to do that?
Well, as we've talked about this morning...
No, you as an individual, as a naval officer, used to leadership roles, running a hospital, multiple hospitals, command, how do you plan to instill that based upon your position that you're in now?
Well, I am now in a position to require improved oversight and strengthen our accountability measures. The offices that provide the policy and that perform the medical legal reviews belong to my part of the organization and to Dr. Elna Hall, so we're both in a position to make sure that our strengthened policies and our approaches are carried out in a more satisfactory manner.
But you are the man at the top of the pyramid right now, right?
I guess this part of the pyramid, yes, sir.
Okay, but the rest of that pyramid that's below you knows that there's a new sheriff in town?
They do.
Okay. Well, I would suggest to you that if they don't, they should get that word right away because, as Dr. Dunn said, failure is not an option, and it comes from the top on down. And with that, I just got a couple of seconds here. I'm going to yield back the remaining 10 seconds, and we're going to go to a second round for anyone else who would like to ask a question. So having said that, Ranking Member Custer, you're good, right? Okay. Mr. Poliquin, you are recognized for 5 minutes.
Thank you, Mr. Chairman, very much. Mr. Chairman, I'd like to submit for the record the testimony from Jake Myrick, a terrific veteran of 15 years who suffered under the care of Dr. Thomas Franchini up at the Togus Medical Center in Maine. Dr. Cox, I'd like to ask you a couple questions if I can. When you have a situation as I described where a medical center, in this case, the Togus Medical Center in Augusta, Maine, knew and confirmed in April of 2010 that, in fact, Dr. Francini had botched multiple surgeries on 87 of our veterans, one which resulted in a leg amputation just to relieve the pain. The VA knew about this. The local medical center knew about this in 2010. They did not inform the patients who had been harmed, these 88 patients, until 2013, 3 years later. The statute of limitations is 2 years. First of all, I don't think anybody in America would think that it is fair to deny these 88 men and women who served our country in uniform the opportunity to file claim against the VA, against Dr. Francini, or whomever. They should have their day in court. So my question to you, Dr. Cox, and possibly to Mr. Williamson, is do you have any evidence or any belief that the VA waited until after the statute of limitations expired deliberately to avoid liability? Mr. Cox?
Congressman, I know of no such evidence that would suggest that anybody did anything deliberate of that sort.
Mr. Williamson?
I can tell you that if the situation described is accurate, that should have been something that would have been a subject of review and a process. I don't understand it either.
Okay. I'm thinking, Dr. Cox, what the heck, not me, what you and the VA tells Jake Myrick. You can't give him back the years that he lost with his family while he was suffering depression, had to quit his job. What do you tell April Wood, who has one leg now? You can't return that. Is there a process whereby the statute of limitations language can be accepted? Is there an appeal process? Is there something that not only these two warriors, but anybody else who has suffered under this sort of quackery can still file a claim even though the statute of limitations has expired, not because of any fault of theirs, but because of the fault of the VA? Dr. Cox?
Well, first of all, let me say I'm greatly troubled by the stories that you're telling and that I've read about regarding Mr. Myrick, Ms. Wood, and the other veterans that were harmed by Dr. Francini.
Thomas Francini.
And
make sure everybody knows who he is.
And there's no question in my mind, from what I know of this case, which, as you said, is from several years ago, that the medical center didn't do the job that they should have done. It took far too long from the time of discovery around 2009, 2010 of Dr. Francini's complications and problems of surgery to conduct the review and to eventually, over 2 years later, report him to the 5 states where he was licensed. That's far too long a time, and that's not acceptable.
Is there any way to adjust the law such that there is a process whereby they can still file claim, even though the statute of limitations has been exceeded?
Well, Congressman, I'm not a legal expert.
Who could answer that question for me,
attorney,
Mr.
but
Cox?
I know.
Who could answer that question for me, Mr. Cox?
I know that there is a U.S. District Court action that is still open, and the judge is considering that very question and will hopefully rule soon, I believe.
But there's nothing can be done within the VA itself. If I call Dr. Shulkin about this, no, it's in the hands of the courts now. Is that correct?
As I understand it, that's correct.
Okay. Yield back my time, Mr. Chairman. Thank you very much.
Thank you. Dr. Dunn?
I just want to very briefly point out that we keep saying that this failure to report to the National Practitioner Data Bank is illegal. It is, in fact, a crime to not do that. So we have a number of criminals who are Veterans Centers directors at this point. I mean, that actually is a federal crime. You know, I certainly had to operate under that law for 35 years. I just wanted to underscore, you know, we said it's illegal, it's a crime. And I'll bet the statute of limitations isn't up on that. I yield back.
Mr. Arrington, you're recognized.
Thank you, Mr. Chairman. Mr. Cox, I want to follow up on my line of questioning earlier about when did we know, when were you guys aware, when was the VA aware that this area, this very important area, was without management, oversight, accountability? I mean, I don't expect perfection, and I don't think anybody up here does. I don't think the taxpayers. This is a large organization, and I certainly am not perfect in my organization, even a small one like my office. But I expect consistent delivery on what we promise that we're going to do for people, and in this case, excellent care for our veterans. So my question again is, when was the first time you were aware that in this very important area, and I don't think you would dispute this is critical to the care of our veterans, when did you know this sort of review and reporting was not taking place?
Well, as I said before, we became aware of these specific cases when the GAO conducted its audit.
Did you do an audit prior to the GAO's audit, an internal audit?
No, there was no internal audit done of this area. The thinking within VA for a long time has been that reporting is a responsibility at the local level, and it is indeed the medical center director that bears that responsibility. And we...
What responsibility does the secretary and the central office have to make sure that these important controls are in place to make sure that veterans don't get hurt and they're not trapped in a healthcare system that is so fundamentally broken that they have people that have had adverse actions taken against them, have limited privileges still practicing it? At what point does Central want to understand that that, in fact, is going on or not going on, and where to shore up where the gaps are? I mean, you were the Inspector General for the VHA. Why wouldn't that be a regular audit so that we know that we were taking care of our veterans and not putting them at risk?
Well, I can tell you I certainly am interested in knowing that we are reporting providers appropriately, and now that this has become...
How could you care and not have an audit and wait for the GAO to come in and reveal to the world now how non-existent the oversight is in this area? I mean, that's the problem. The message to me is, and I know that you do care as an individual, but the VA system doesn't care. The system's the enemy for me right now. The bureaucracy is the enemy to this, to our most precious commodity, our most treasured asset, our wounded warriors, and the system is the enemy. They don't care, or they'd have had controls in place, right? So I know to every individual you'd say that you care, and I believe you as an individual, but the organization doesn't. And yes, sir.
I think as an organization, we have for too long entrusted that people are doing the right thing, and we haven't checked. I mean, that's what oversight really is, right? Checking to make sure that...
But if it was your son, if it was your spouse, you wouldn't tolerate that. Treat these people like they're your children. Treat them like they're your spouse. And we won't need policies. We won't need hearings. Would you agree with that?
I would.
Okay. Mr. Chaudhry, you've seen a lot of healthcare systems, no doubt, in your tenure in the current role over these state licensing boards. With respect to the private sector, and this particular area of reviewing complaints, and then when there's findings, reporting that out and taking action against physicians who are incompetent or acting unprofessionally and unfit to practice, would you say, comparatively speaking, to the folks that you've interacted with on the outside of the VA, for-profit or non-profit, that the VA is above the average, or below average in this area?
Congressman, based upon the conversations that I've had over the years, and I've been in my role 9 years, this is not a brand-new issue. We never knew the extent of it.
Brand new issue for the VA or for life and like all healthcare systems?
In terms of the VA
Okay.
system. So I've heard of anecdotally reports over the years, but my concern is, as what the GA report suggests, that it may be below.
Okay. Mr. El Nahal, do you represent the central office, the secretary's office? Who do you represent here today?
Congressman, I report to Dr. Cox as the head of quality, safety, and value for the VHA.
Okay. Well, I hope Central engages. I believe in this secretary. I really do. I've heard enough from him, engaged enough with him, and I know this president cares about our veterans, and I know he won't tolerate this sort of subpar organizational management. And so I'm hopeful, but it's going to take a lot of time. And we're going to stay on you, and I'm going to stay on you. And then I'll help you any way that you tell me you need help. If you need tools you don't have, resources, I know our chairman will do the same, and I know the chairman of the subcommittee feels the same. But we're going to stay on you until this thing is fixed, until you do right by our veterans. With that, I yield back, Mr. Chairman.
Thank you. Ms. Gonzalez-Colon, you are recognized for 5 minutes.
Thank you, Mr. Chairman. I want to follow up on my first round. And Dr. Cox, I mean, we were talking about having those directors and those staff being capable and committed to submit that information to the data bank and to the state license. And I asked directly, what do they face if they are not doing their job? And you told me directly that the new law provides direct actions from the secretary. Is there any other action?
I'm sorry, I missed the last part of your question.
Is there any other action that can be, that those employees can face after committing this crime?
So no actions have been taken against the medical center directors that were involved in the GAO's audit. We only, in the last few days, became aware of what those centers are, but that process of review and potential disciplinary action is now underway.
Okay, and we're talking, I mean, this is big. This is not just only our veterans, which is very disturbing. We're talking also about all patients in the outside community that are receiving the same treatments from the same providers that are actually treating badly our veterans. So this is a very big problem that it's outside of VA. It's irrigating the whole community, and that's the reason we have a database. That's the reason we got a state license to prohibit this kind of conduct to happen. One of the issues that I want to bring now is and to you. You, in your testimony, you said that you expand the range of the clinical occupations that should be reported to the National Practitioners Database, including other medical professionals aside from the physicians and dentists. How, if you are expanding those, if we can't even comply with the physicians and the dentist?
Well, the decision to expand the range of healthcare professionals.
And I do agree on that.
Yes, and I agree as well. That decision to expand the range of professionals that will report stems from concerns such as Representative Poliquin described it at Togus, Maine, where the individual involved was a podiatrist, not a medical doctor, not a dentist. And so the requirements of the Department of Health and Human Services to report adverse privileging actions.
But how to comply? If you can do it right now with the law, what the law provides, and you did this in an administrative way voluntarily, how can you provide for that expansion when you can't do the one that is required by law?
We certainly can pay greater attention to it, enforce our policies, conduct the oversight, conduct the audits to make sure.
This is enforcement. I mean, we can have all the policies, but if we can't enforce them, we will have the same problem again and again. Mr. Williamson, I just want to know, what are some of the reasons, if there are any, that the vast majority of providers in your study were not reported to the National Practitioner Data Bank when required?
There's a couple of reasons that you've mentioned already, some of them. A lot of the staff we talked to didn't know what the responsibilities were, that they had responsibilities for reporting. And even in the cases where they did, they were confused about under what circumstances they should report. For example, as Chairman mentioned a while ago, there was a misconception among center staff that they shouldn't report contract providers. That's totally false.
Is there guidelines?
Yes, it's in their policy.
It's in their policy. So
Yes.
it's a written statement.
Correct.
And they are instructed to do so.
They asked central office, and central office, somebody in central office told me didn't have to, but it's in the policy, so it's, you know.
Just hearsay.
Yeah. Also, one of the cases where VA didn't report, or one of the medical centers didn't report 6 people. This medical center director delegated it to the Human Relations Department. That was in the medical center, the local medical center policy. And when we talked to the Human Relations Department, they were not aware they had a report responsibility. It's really outrageous that people are not being told about the responsibilities and don't know their job like they should.
Thank you, Mr. Williamson. And just to, last question to Mr. Cox. What is going to be happening with the employees from the VA that are having tailored reports with settlements reaching settlements that reduce the impact of faulty services? What is going to be happening with those federal employees? And with that, I yield back the balance of my time.
So very briefly, and as mentioned before, any employee that's involved in negotiating an improper settlement will be appropriately disciplined.
Thank you. Mr. Peters, you're recognized for 5 minutes, sir.
Thank you, Mr. Chairman. First, I want to just apologize that the way things work around here is they schedule both your hearings at once, so I was at a Energy Subcommittee hearing. And so I'm going to ask, I have one question, and I apologize also if you've already addressed it, but it's a particular concern of mine. And maybe if you answer it the second time, you'll like your second answer better. I guess to the GAO, I guess the question would be about the IT system. I want to know if you've had a sense of how the VA's antiquated IT system or the data tracking methods have hindered efforts to provide good provider quality. And I'm asking this as a way to suggest or to help the VA get the right kind of IT system that can help achieve better care and more efficient service delivery. And just ask you if you could respond to that. I'd appreciate it.
Well, my teams have done a variety of audits, looking at choice, looking at claims, payments, and a number of other things. And IT is always at the top of the list as far as a root cause for not having good data, not being able to track things. And if you don't have good data and you don't have a system for tracking, oversight's pretty difficult, not impossible. So yes, IT on a broad kind of scale is probably one of the biggest problems that VA faces.
Are you familiar with what the VA today is doing to address that issue, and do you offer any suggestions for them?
Excuse me?
Are you familiar with what the VA is today doing to address IT, and do you have any suggestions on that?
Somewhat. That's not my area, and I know they have taken a number of actions in the past. Some failed attempts to come up with large data systems. Right now, they're working on it, but I think we've issued a number of reports recently that's talked about some shortcomings, and I think Secretary Shulkin's decision to take an off-the-shelf IT system to remedy the electronic records problem and its operability with DoD, for example, is a good step.
That's my sense too. I think Secretary Shulkin has put the right emphasis on this, and we don't need to reinvent the wheel here. Probably wheel inventing is not our strength, and so I'm happy to see that. But just in the time I have remaining, you have particular instances or examples for how the failure of an IT system has affected provider care? More specific examples?
I'm not sure I do, although in this case, in the case of the audit we're currently talking about, we found that as far as tracking reviews, the reviews done when care concerns have been raised at the medical center level, right. It's very fragmented. You couldn't walk into a medical center and ask for a list of reviews underway when care concerns have been raised. We had great difficulty doing that when we identified our 148 cases. So there's no electronic tracking of that. I mean, if you had an up-to-date modern system, you do that electronically. You do it in a central repository in the VAMC, such that if you wanted a list at any time, somebody could produce it for you.
Well, thank you for that. Thank you for the work. We talk a lot about accountability in this committee. We're committed to it. Obviously, you can't achieve accountability if you can't get a sense of whether we're moving in the right direction and can't keep up with things. So I appreciate that. Look forward to working with the committee on that, and yield back.
Thank you. Dr. Rowe, you're recognized for 5 minutes.
Thank you. I will respectfully disagree with Mr. Williamson. It maybe makes your job a little easier, but I can assure you, before there was ever one of these things anywhere near me, we knew how to evaluate our staff, and we knew how to keep records, and we knew how to do this. Quality of care has been an issue for years, long before there was a computer chip. And it'll make it easier to trace, I admit. And Mr. Peters, I just got back from Fairchild Air Force Base, and I think this implementation of the Cerner system is going to be a little harder than I thought after visiting out there. But I guess my question to Dr. Cox or to anyone at the VA is, why would it take a GAO investigation to determine just simple, basic medical staff functions like this? That's what still baffles me, is because I don't know why Mr. Williamson was ever needed to go out. This is such a basic function of a medical staff. Credentialing and quality of care in your facility. I mean, that is the thing that I've focused on for over 30 years, because if people lose confidence in your hospital, they'll quit coming there. And they'll quit coming to you as a physician if they find that out.
Well, Mr. Chairman, I agree that it's indefensible. And I can only speculate. I just wanted to point out that these decisions about reporting somebody to the data bank or potentially taking an action that'll affect their license are never taken lightly. You know, as you know, these are complex and serious matters. Yes. You're dealing with professionals who've had years and years of professional training, 4 years of college, 4 years of medical school, 3 to 7 years of residency training, maybe more in certain specialties. And so when the person who has the authority to make that report also has a very serious responsibility, both to the veterans and the rest of the community, but also to bear in mind that that decision could, in fact, impact that provider's livelihood. So that's not an excuse for anything, but it is to point out that when I had to wrestle with these decisions, I wanted to make sure we had all the facts. I wanted to make sure that they were all collected properly, and that my decision was based on sound evidence.
No, look, I was going to say that I could not agree with you more. I mean, I've been on the Credentials Committee, and it is a weighty decision when you have a professional that's there that's spent all these years. I totally get this. There's two sides to this equation. Yes, sir. But at the end of the day, we still have, as medical staff people, the patient's safety and quality of care is utmost. And I agree with you. You have to do that. Well, one of the things that's bothered me since I've gotten here is this bill that Ms. McMorris Rogers, myself, Mr. Poliquin have. We make laws because people are not doing their job, and they're unnecessary. The bill that we've got really ought to be unnecessary, because if the medical staff had done its job, you would need to have a law that now complicates things even further, I think. So I would encourage you, and one of the things I would encourage you to do when you go back, this is not only embarrassing to a great organization like the VA, to the medical profession. To me, it's embarrassing to me as a physician that this went on. But if I were you, I would go back and instruct every VISN director and every medical center director to be sure that that policy was totally understood by my medical staff and how it was carried out. And every hospital has this system set up. So I would make sure that every 150 plus those medical centers had checked that box and said, we know how to do this and are doing this. And that's the other thing I want to know is that how many providers have been reported to the National Data Bank or to the state agencies. I want to get that number and find out how many you have actually done, because it's a big step. I realize that, to do that.
Well, I agree with you, Mr. Chairman, and that number is not easy to come by now because we haven't been tracking it centrally. We can track, and I could tell you the number and be happy to provide it afterwards, of those providers that were subjects of a malpractice claim, right? If there's a paid claim or a settlement, we actually do very well with compliance rates in the last 3 years of 95 to 98% in reporting providers who are named in a malpractice case. But what we have not been tracking and what we can't easily tell you at this moment is those individuals who were named because of concerns about the quality of care locally, where there was an adverse privileging action but not a malpractice claim.
This is what I don't want to see happen. I don't want to say, whew, that's not my problem anymore. And then now it's somebody else's problem, because I've dealt with that. And, you know, once you get someone on a medical staff, as you just pointed out, Dr. Cox, it's very hard to then dismiss that person from the staff. So you're better off doing your due diligence to start with. And Dr. Chadwick, he's out there as a state licensure. If he doesn't have that information, he makes a bad decision. So I think it's bad decision, and we have to do. We don't need to. We have to do better. So I yield back.
Thank you, Dr. Cox. VA has the option to provide orders from its providers' disciplinary boards to the FSMB when they take action to preclude or limit a provider's ability to practice within the VA. According to Dr. Chowdhury's testimony from 2007 to present, VA has not sent any such reports to the FSMB. Why not?
I'm afraid I'm not sure what the situation has been regarding the FSMB. You know, regarding individual state licensing boards, as the GEO pointed out and as we've been discussing, there's no question that we have not been making reports with the frequency that they should have been made.
Okay, Dr. Chowdhury, in your testimony, you state that many of your constituents' boards have found VA does not report providers in a timely fashion, and that the VA is often unable to adhere to reporting standards outlined in its own guidance. Why do you believe the VA is unable to adhere to its own guidance and standards?
So I think that question is best answered by the VA, but as Dr. Cox has indicated, I think it's a local issue is the best that I can interpret. So all these discussions are helpful in terms of moving forward. If I can make a quick comment, Chairman, about the FSMB, we have a database of all physicians wherever they are licensed. Increasingly, physicians are licensed in more than one jurisdiction. The value of the VA sharing that with the FSMB's database is we can share that with all the state boards where that physician who works in the VA is also licensed, so that it's shared not just with the licensing entity where that physician is licensed, but also additional licenses, so that everyone has information. And we have a data sharing agreement with the VA which encourages the VA to do that, and I would be interested in strengthening that recommendation as well.
Okay. Mr. Williamson, as you know, it is against the VHA policy to enter into an agreement with a provider stipulating that the VA will not report the provider to the NPDB or state licensing board in return for their resignation, retirement, et cetera. Did you find any evidence of these types of agreements in your review?
No, we did not. And we didn't look at the settlement process per se. We came across 2 settlements that were in our sample of 148. And as you know, VA policy prohibits they must report, even though the settled agreement is reached on some other thing. That's non-negotiable.
Okay, thank you. Ranking Member Custer, do you have any? Okay. Well, I did a quick back of the napkin math here, Mr. Williamson. You and I must be similar in age, so my congratulations to you on the length of your career. Now, how's your health?
What's that?
How's your health?
It's good. That's why I'm retiring.
Okay, so the point is, I look forward to hearing of your relaxing, recharging your batteries, because given the longevity tables, for someone in good health, you have at least one more career in front of you. I would suggest do something different than you've been doing for the last 40 years. It will rejuvenate you.
That's what my wife tells me, too.
I mean, 50 years. I apologize, 50 years. I was doing my math in the Marine Corps and applied it to yours. Maybe 40 years in the Marine Corps seems like 50 years somewhere else. Congratulations to you, and job well done. Thank you, witnesses, for being with us today and sharing your testimony. The panel is now excused. Today's discussion has illustrated the importance of proper management, of competency and privileging processes, and the consequences of failed oversight. Healthcare organizations are responsible for validating the competency of their medical staffs through a credentialing and privileging process. These processes are important, essential, and closely tied to reimbursement, accreditation standards, and state and federal laws. At VA facilities, these processes influence the quality of a facility's workforce, which at VA determines the quality of the care that veterans receive. The fact that VA is taking 3 months to, in some cases, years to review quality concerns is entirely unacceptable. But perhaps more outrageous are the cases where VA uses taxpayer dollars to settle cases with clinicians who have provided substandard care to veterans, essentially to just make them go away. That is not what my fellow veterans and our constituents deserve. Ensuring underperforming providers are held accountable is a burden shouldered by the entirety of the American healthcare system. But as the country's largest integrated health system, VA has a particular responsibility to hold themselves to the highest standards for managing quality and safety concerns. The testimony presented today highlighted the lack of urgency and the VA's disregard for the domino effect a dysfunctional privileging and reporting process has on its patient population, allowing the same concerns to persist year after year. Each of us gathered here today would agree that our nation's veterans have earned high-quality health care. We would also agree that the VA's ability to deliver quality care in a timely manner depends largely on its actions it takes to review and report potentially questionable actions of the providers it privileges. Therefore, we will continue to track VA's progress closely in addressing the concerns brought forth today, both from the GAO and offered during today's discussion. Now, I heard early on in the testimony today the phrase incompetent. There's a difference between incompetency and unprofessional behavior, and I would agree with you wholeheartedly. I would suggest to you that leadership and culture will go a long way towards taking care of unprofessional behavior. Incompetency is just that, and it is a leader's responsibility, an organization's responsibility at all levels to self-report and to ensure that if a provider or anyone is deemed incompetent after given ample opportunity to bring their performance up to standards, that they be dealt with immediately and not continued to be led down a path that you know as a leader they cannot attain that level of competency. I'm going to call you Captain Cox here for a minute rather than Dr. Cox or, Acting Assistant Deputy Secretary Cox. As a leader of a hospital, you had that staff, whether they be the nurses, the doctors, the PAs, the nurse practitioner, whoever it was, under your command. You knew as the leader at the top of that pyramid in that hospital, you didn't call DC, you didn't call someone else. You took leadership action because as a captain, as a commissioned officer in the United States Navy, it was your responsibility to hold yourself accountable and therefore hold others accountable. You're the new kid on the block here. You have an opportunity to show what it means to be a true leader to the entire Department of Veterans Affairs as it relates to physicians and providers. Don't miss the opportunity to be a leader. By the way, you may think that you heard emotion from our committee members here. That was not emotion, that was passion. Passion for the veterans, passion for providing the best medical services possible, and taking no excuses for lack of performance. And you also heard in several cases that this committee should not have to create new laws to get the VA to enforce the current laws and policies. They exist, use them. This committee as a whole, the subcommittee as a whole, the committee as a whole is so committed to giving the VA every tool necessary. You have to use the tools. If you don't, there will be consequences. Again, I thank you for being here this morning. I ask unanimous consent that all members have 5 legislative days to revise and extend their remarks and to include extraneous material. Without objection, so ordered. Again, I'd like to once again thank our witnesses and the audience members for joining us here today. This hearing is now adjourned.